Good night, everyone. My name is Elan Coker. I'm one of the neurosurgery house officers at San Fernando General Hospital, and I will be presenting choroid plexus tumors. So these are my objectives. So firstly, what is the choroid plexus? So the choroid plexus is a highly vascular structure within the cerebral ventricles, which comprises of choroidal epithelial cells, loose connective tissue, which is also known as the tela choroidea, which is a part of the pia mater, as well as permeable capillaries. The main function of the choroid plexus is the production of cerebrospinal fluid. It accounts for 70% of the production of the cerebrospinal fluid, with the latter 30% being from the ultrafiltration of water. In terms of the cerebrospinal fluid, it acts as a cushion for the brain, limiting neural damage in cranial injuries. It also allows for buoyancy, with the brain being sub-immersed in the CSF and thus reducing the excessive pressure on the base of the brain. It also acts with respect to the chemical stability, allowing for the proper functioning of the brain. The choroid plexus also forms an aspect of the CSF blood barrier, along with the arachnoid villi and the arachnoid. In terms of the choroid plexus, in terms of the vasculature of the choroid plexus, it can be looked at the areas that it supplies in terms of the lateral ventricles, which are supplied by the anterior choroidal artery, which is a branch of the distal branch of the internal carotid artery. The third ventricle is supplied by the posterior choroidal artery, which branches from the posterior cerebral artery. The posterior choroidal artery also supplies the lateral ventricle, but has more of a minor role. In terms of the fourth ventricle, it is supplied by the anterior and posterior inferior cerebellar arteries, which come from a branch of the basilar as well as the vertebral arteries, respectively. In terms of the location of the choroid plexus, it may be found in the roof of the temporal horns of the lateral ventricles, extending along the floor of the body of the lateral ventricles, through the interventricular foramen of one row, and along the roof of the third ventricle. It doesn't typically extend to the frontal or occipital horns of the lateral ventricle. So in order to understand what is abnormal with respect to the choroid plexus, we have to know what is normal. So with respect to imaging, the choroid plexus may appear iso-intense within the ventricles. And in terms of contrast, due to its high vascularity, it tends to enhance. So on to the choroid plexus neoplasms. So these are rare neoplasms derived from the choroid plexus epithelium, and they occur within the ventricular system of the brain. They account for 0.4 to 1% of all intracranial tumors, accounts for 2 to 5% of all pediatric brain tumors, and it's found predominantly in children. These tumors account for 70% of these tumors can be seen in children under 5. It has a relatively higher incidence in slight incidence in male over females, and there is also a genetic component that can be seen associated with Aicardi syndrome, which is a syndrome of hypogenesis or agenesis of the corpus callosum, as well as in Li-Fermani syndrome, which is a germline mutation of the TP53 gene. In terms of the sites of the tumor, it is most commonly found in the lateral ventricles in children and in the fourth ventricle across all ages, but it's more so found in the fourth ventricle with respect to the adult population. It may be rarely found in the spinal cord or ectopic sites. In terms of the presentation of these tumors, the clinical presentation, it's most associated with signs of increased intracranial pressure. As highlighted before, the primary role of the choroid plexus is the production of cerebrospinal fluid, and as such, the proliferation or any pathology of the choroid plexus may involve increased production or overproduction of CSF. In infants under the age of 18 months, this may be associated with macrocephaly. So the anterior fontanelle closes between 7 to 18 months, and the posterior fontanelle closes at around 2 months. So these patients can present with increasing head circumference, crossing percentiles. Patients may also be irritable, have instances of poor feeding, and as such resulting in failure to thrive. There may also be neurological impairment leading to developmental delay and failure to achieve milestones. In terms of the older pediatric population, they may present with headaches, drowsiness. They may present with loss of appetite, nausea, and vomiting. If it's associated with carcinoma, it may present with constitutional symptoms such as weight loss and fatigue. And they may also present with cognitive difficulty, with impairment of concentration, changes in personality, and regulation of mood. The adult population presents similarly to that of the older pediatric population in terms of nausea and vomiting, may be associated with blurred vision, may have seizures, as well as headaches, which may be notably worse on position, may be notably worse positionally, as well as it's usually worse in the mornings. These tumors may also, the presentation of these tumors may also be related to the site. For instance, if it's found in the fourth ventricle, there may be compression of the cerebellum, resulting in difficulties with balance. In terms of the WHO classification of these tumors, it looks at the histological classification in terms of the architecture, the preservation of the pupillary pattern that is typical of the choroid plexus, the cellular density, the cytology, as well as the proliferation. It also looks at the presence and absence of necrosis, as well as brain parenchymal invasion, as well as involvement. So with respect to the choroid plexus tumors, according to the WHO classification, there are 3 main grades. So the first grade is the choroid plexus papilloma, which is WHO grade 1. These are considered benign, slow-growing tumors. The atypical choroid plexus papilloma, which is termed WHO grade 2, and these are thought to be immediate grade tumors with a higher risk of recurrence compared to that of the choroid plexus papilloma. The choroid plexus carcinoma is known as a malignant tumor, and it's more likely to spread. So firstly, the choroid plexus papillomas. So these are uncommon, benign neuroepithelial intraventricular tumors that can occur in the pediatric population and adult population, with it occurring more commonly within the pediatric population. These tumors, as said before, are termed WHO grade 1, and the features are in keeping with low mitotic rates. It's also known that these tumors bear great resemblance or are similar to that of the normal choroid plexus, with their structures showing delicate fibrovascular core, lined by columnar or cuboidal epithelial cells with vesicular basal nuclei. They may also show papillary finger-like architecture, as well as there may be some loss of cobblestone surface. As said before, they have a low mitotic rate and very mild nuclear pleomorphism. Of note, there's a lack of necrosis. In terms of the epidemiology of these tumors, it comprises of 2 to 6% of the pediatric tumors and 0.5% of the adult brain tumors. There is a disproportionate representation in children under 1, where most of these tumors occur in children under 1, and approximately 85% of all choroid plexus papillomas occur in children under the age of 5. There have been associations with several diseases such as hemangioblastomas, Aicardi syndrome, which has been mentioned before, and the von Hippel-Lindau syndrome. With the choroid plexus papillomas, the clinical presentation is more so of hydrocephalus. So as said before, these patients may appear with macrocephaly, with the head circumference crossing percentiles. And thus it's very important to ensure on each visit that the head circumference is properly documented. Symptoms are usually in keeping with increased intracranial pressure in at least 80% of patients. And due to the overproduction, as stated before, it results in a communicating hydrocephalus. So this is a macroscopic appearance of the choroid plexus. It has a cauliflower-like appearance to it. In terms of the microscopic features, these tumors may demonstrate a papillary structure with a delicate fibrovascular core. And as said before, they are lined by columnar or cuboidal epithelial cells with vascular basal nuclei. Their appearance is thus similar to that of the normal choroid plexus. In terms of the radiological findings, it's usually associated with a well-defined lobulated mass and may appear either isodense or somewhat hyperdense in comparison to the adjacent brain. So in this slide, you can see that there's a T1 axial cut of the brain showing that there's enhancement of this lesion that is located in the left posterior aspect of the lateral ventricles. And on the right, there's a T1 axial that is showing isodense lesion that is in keeping with this tumor. So in terms of the radiological findings of the MRI, it may have a front-like morphology of the tumor and can usually be seen, especially following contrast administration. There may be varying degrees of associated hydrocephalus present in these cases. T1 usually shows isointense compared to the adjacent brain and may be somewhat hypointense. T2 tends to be isointense as well as hyperintense. The T1 contrast may show marked enhancement and tends to be homogeneous. In terms of the MR spectroscopy, there's associated decreased NAA, which is may also be seen in other tumors, as well as in FOX. And increased CHO is directly related to increased cell turnover. So these are the MRI images. So on the left, you can see the T1 image showing a cauliflower-like mass in the right posterior horn of the lateral ventricle, as well as this is a T1 scan, non-contrast scan, that is showing a similar tumor. In terms of angiography, this may show the vasculature of the tumors and may also help in terms of the preoperative planning if embolization may be required. Immunophenotyping is also helpful in the diagnosis of these tumors in terms of the presence or absence of these proteins, in terms of the cytokeratins, which are usually positive, the vimentin, which is positive as well, and there's a better prognosis associated with the S100 and the transthyretin, which is usually seen within the normal choroid plexus. With respect to treatment, the total excision should be the aim of therapy, and it's usually curative in these cases. Due to the high vascular nature of these tumors, as stated before, embolization would be beneficial to decrease blood loss intra-op. Overall, there's a 90% 1-year survival and 77% 5-year survival. CSF seeding is uncommon in choroid plexus papillomas, but far more common in those of the high-grade pathologies. So the atypical choroid plexus papillomas. So it is important to note that in terms of imaging, whether that be CT or MRI, it is difficult to distinguish the WHO grade 1 choroid plexus papillomas from the atypical choroid plexus tumors. And as such, the diagnosis more so hinges on the histological diagnosis in terms of seeing the increased mitotic activity, the increased cellularity, and blurring of the normal papillary anatomy. There may or may not be features of necrosis. In terms of the choroid plexus carcinomas, these are malignant neoplasms arising from the choroid plexus, and they are termed as the WHO grade 3 tumors. So these tumors occur predominantly in children, typically in the first 5 years of life. They are thought to be rare, and they are far less common than the choroid plexus papillomas, which account for 80% of the primary choroid plexus tumors, representing only 1 to 4% of pediatric brain tumors. In terms of associations, these may be associated with the Li-Fraumeni syndrome, which is the TP53 germline mutation, as well as the simian virus has also been linked to carcinomas being found in at least 50% of cases. It has also been linked to the Arcadi syndrome. In terms of the presentation, patients may present with symptoms of hydrocephalus, even though this is less common than that of the choroid plexus papillomas. And if hydrocephalus occurs, it's usually due to obstruction. Symptoms as such may be reflective of that of increased intracranial state. So this is these are the macroscopic features of the choroid plexus carcinomas, showing areas of necrosis. In terms of the choroid plexus tumors, with respect to the microscopic features, there's increased mitotic rates over 5 per 10 high power field. There is increased cellularity. There's increased nuclear polymorphism. There's presence of necrosis, and there's blurred papillary structures. So as these tumors are more specifically found in children, it can be detected via ultrasound in children who have been found to have hydrocephalus. It may be an incidental finding. So these are the CT images showing the hyper-intense lesion, and there may also be features showing invasion of the surrounding brain parenchyma, which is more typical of the carcinoma. In terms of the MRI findings, it tends to be more iso to hyper-intense. On the T2, it's iso to hyperintense and may show areas of necrotic tissue, of necrotic areas, sorry. And there may also be features of calcification and hemorrhages. On the T1 contrast, it shows great and it may show heterogeneous enhancement, whereas with the papillomas, it shows more homogeneous enhancement. Right, so this is a T1 axial showing the lesion within the right posterior horns of the lateral ventricle, and it's showing that there is also invasion with respect to the surrounding brain parenchyma. This is an image showing the T2 coronal, and you can see the heterogeneity as well. In terms of the choroid plexus carcinomas, immunophenotyping is also helpful as well, with cytokeratins being positive, S100 being negative, whereas with the papillomas, it's more so positive, and transthyretin is also negative. The P53 protein is commonly positive in those individuals with the TP53 mutation. In terms of treatment and prognosis, surgical resection or complete surgical resection is effective in 50% of cases. The prognosis is directly dependent on the extent to achieve complete resection, and the 5-year survival is up to 86% in these cases, whereas incomplete resection may drop the rates as low as 26%, and thus there's a higher chance of recurrence. Adjuvant therapy, such as chemotherapy and radiation, is also imperative part of the treatment of these patients. In terms of the prognosis, the poor prognostic factors would be that of the TP53 mutation, as well as features of brain parenchymal invasion, and if there's CSF seeding, as this would result in recurrence. With respect to choroid plexus metastases, this accounts for less than 5% of intracranial metastases, and that has been seen in the autopsy series, and less than 1% of clinically evident cerebral metastases. So these are thought to commonly occur with respect to the hematogenous spread. As we said, that the choroid plexus is highly vascular, so therefore it favors that spread. In terms of tumors that are more likely to spread to the choroid plexus, that would be the renal cell carcinoma and the lung carcinoma. Less commonly, it's the colon, gastric, breast, thyroid, and bladder cancers, as well as melanoma, lymphoma. Within the pediatric population, it's more so associated with Wilms tumor, neuroblastoma, and retinoblastoma. Right? And this is just a slide showing a patient with renal cell carcinoma that had metastases to the choroid plexus. Okay, so these lesions are usually amenable to surgical resection, although the prognosis is directly related to the type, as well as the stage of the primary cancer, as well as the extent of the metastatic dissemination. So these are my references, and thank you for listening.